I think the first thing I should say here is, although I'm presenting this work, it's been a team effort. There's a research team mentioned there in the paper that was under review, and the main person who did the analysis is Catherine Friel, who couldn't be here today, but she deserves most of the credit for this study. So this is just an overview of what I'm going to talk to you about. I'm going to talk a little bit about the policy and key trends and health benefits relating to active travel. I'm then going to talk about the actual study and our findings. And then I'm going to talk at the end more about the implications for building active travel infrastructure investment, some of the challenges we face, and I'll finish off with some conclusions. So lots and lots of policy here around which are really quite progressive and linked to do with addressing climate change, to improve air quality, to improve places, to get more people cycling. We've got a national transport strategy, which is about making a shift to a sustainable transport system. We've got a vision for a more active Scotland, and we've got a proposal for reducing car kilometres travelled in Scotland by 20%. And if you look at all of these strategies and policies, you will see a lot of support for increasing levels of active travel. And indeed, we're seeing government commitments to that. We're seeing a big increase in active travel budget, and for next year, the commitment is that £320 million will be spent on active travel infrastructure and behaviour change in the next year. That's 10% of the total transport budget and is very significant, much higher, for instance, than in the Netherlands currently. So all looks good, but there are a few challenges which I'll highlight. This is an illustration of the carbon emissions that come from transport comparing 1990 to 2018, and you can see there's barely any change in carbon emissions from transport in that period whatsoever. And in fact, road transport is taking up a greater proportion of transport emissions. It's up to 68% now. There's also the way we move around and use and how dependent we've become on cars. Now, commuting is about 23% of all the journeys we take, so it's quite a significant contribution to transport. So I'm just going to show you this challenge in terms of this graph, which shows commuting trends over a 45-year period across Scotland from 1966 to 2011. And I'd like you to imagine 100 commuters. So back in 1966, 21 in 100 travelled by car to work, but by 2011 this had trebled to nearly 70 in 100. Not surprisingly, given that stat, other modes decreased. 24 people out of 100 walked to work in 1966, but by 2011 that was down to 11 in 100. Bus use went down even more, from 43 in 100 commuters to 11 in 100 in 2011. And in this period, people who were cycling to work, it was relatively low over this whole period, between 1% and 2%. A few caveats about what's presented here. It doesn't show the results from the 2022 census, which aren't out yet, so things might have changed. And it also predates the increase in the active travel budget, which started to happen in about 2014-15. Okay, so I'm going to talk to you about some of the benefits of active travel briefly. So if we think about active travel, walking, cycling and wheeling, if you're being physically active, you're reducing your risk of chronic diseases, you're reducing your risk of anxiety and depression, you're not contributing to air pollution, you're not contributing to carbon emissions, you're strengthening your bones, and there's an element of social interaction, meeting people in the street and the like. The evidence around injuries is a wee bit more problematic, and I'll come back to that in relation to our study, particularly in relation to cyclists. And my last point here is that the costs of building this type of infrastructure, this is Sucky Hall Street, is actually much, much cheaper than building a mile of motorway. Okay, so this is quite a busy slide. Don't worry about it, I'll explain it. So this is a study we're involved in with colleagues at Edinburgh University. We looked at the health economic impact of active commuting. So it was a modelling study based on the WHO HEAT tool, which some of you may be familiar with. So I'll take you through just some of the highlights. In 2011, about 14.5% of commuters walked or cycled to work. Putting the figures into the HEAT model showed that that was likely to be producing an estimated €780 million of health economic benefit, essentially from reduced mortality due to regular physical activity. And we also noted that of those people who were walking and cycling to work, about half of them were getting to the minimum target of 30 minutes moderate physical activity per day, purely from their commute to work. So quite impressive levels of health economic benefit from a relatively low level of active commuting. So that was all about mortality, but there's clearly other co-benefits of regular active travel: reduced hospitalisation for chronic diseases and mental health benefits, and I'll be touching on that in terms of our study, but also there's evidence of lower sickness level, ability for weight control is better with active travel, and if active travel replaces car journeys, we could be seeing reductions in congestion, road noise and air pollution. And we also know that where people are walking and cycling through their neighbourhood rather than driving through them, there's benefits for local economies as well. Okay, so taking us on to our study now, it was designed to assess the health benefits of active commuting in Scotland. Very specifically, we aim to address some of the limitations of previous studies, so we're incorporating a longer follow-up period, a more representative sample of the population, a broader age group, and we're examining a wide set of outcomes. And this is new evidence in a Scottish context, particularly for policymakers and planners. Our main research question was, how does the risk of various physical and mental health outcomes differ between pedestrian commuters and cyclist commuters versus non-active commuters over an 18-year period of follow-up? So we used the Scottish Longitudinal Study, which is a nationally representative sample based on 5.3% of the Scottish population. It's based on a census extract, and it was begun in 1991. Study participants are followed up prospectively, so there's a link to hospital admission records, prescription data and mortality data. And our focus in this study was the 2001 cohort. We used responses to one question in the Scottish census: how do you usually travel to your main place of work or study? And respondents are asked to select which mode of travel they use for the longest part of that journey. So we focused on the working age participants aged 16 to 74 in 2001, and they were followed up for 18 years until 2018. There was a number of exclusions: people who are not commuting, people not working, people working from home. We also excluded records for missing cases, people who are working offshore and those working outside the UK. The analysis we did, there was a descriptive analysis of the characteristics of different types of commuters, and I'll take you through that in a slide or so time. Our main modelling was a Cox's proportional hazard model, which was used to estimate the effect of mode of travel on 9 outcomes to do with mortality, hospital admission and receipt of prescriptions. All the models controlled for a range of demographic, socioeconomic and area-based variables, including distance of commute. And the reference category for all the analysis was against non-active commuters. And I should explain here that non-active includes people who travel to work by car, but also by public transport. And probably with hindsight, we should have split this group because there's an element of active travel at either end of a public transport journey. So we didn't do that, but that's probably a subject for further research. So just a little bit about the different groups we were looking at. I'll talk about pedestrians to start off with. So they're more likely than the other groups to be female. There is a slightly younger age profile amongst pedestrians. They're more likely to be a shift worker. They commuted shorter distances. More pedestrians with lower levels of qualification. They're less likely to be a homeowner. They're less likely to be in a higher managerial profession. They're more likely to live in a city than the cyclist and the non-active. In terms of the cyclist commuters, they're much more likely to be male than the other groups, slightly older age profile than the walkers. They commuted longer distances than the walkers, which is what you would expect. Similar levels of qualifications and occupations to the non-active group, slightly less likely to be a homeowner compared to the non-active, and slightly more likely to live in an urban settlement than the non-active. So coming now to the main results. This is for cyclist commuters to start off with. So compared to non-active commuters, people who cycle to work have 47% lower risk of death from any cause, 10% lower risk of any hospitalisation, lower risks of cardiovascular disease hospitalisation, but also prescriptions for that particular condition, lower risks of cancer hospitalisation, lower risks of cancer mortality, and a 20% lower risk of being a receipt of a prescription for poor mental health. There was one negative outcome, though, for cyclists, and that was that they were twice as likely as non-active commuters to be hospitalised due to a traffic collision. I should say this is a relatively rare occurrence, though, so it's 83 casualties in an 18-year period of follow-up, but it is a double the risk. In terms of pedestrian commuters, slightly less impressive benefits, but they're there nonetheless. Compared to non-active commuters, people who walk to work have a 9% lower risk of any hospitalisation, 10% lower risk of cardiovascular disease hospitalisation or being in receipt of a prescription for cardiovascular disease, and a 7% lower risk of receiving a mental health related prescription. So I think this study provides direct evidence of the association between active commuting and health outcomes over a long period in a Scottish context for the first time. We demonstrate the independent positive associations between pedestrian commuting and cyclist commuting and a range of health outcomes. And I guess one of the questions you might be asking is, given these benefits, what can we say about the potential impacts on NHS costs? So we've done a little provisional work on this, and this hopefully will be the subject of another paper. So I'll take you through this. This is looking at the average cost of hospital care using data from Public Health Scotland, and the figures here are for per cohort individual. So it's over the 18 years of follow-up, the average cost was just less than £6,000, slightly higher amongst inactive commuters. As you can see here, the average is the orange horizontal line. Slightly lower amongst pedestrian commuters, and the average costs of hospital care were much, much lower for cyclist commuters. This is maybe a slightly easier graph to get your heads around. So 1% higher average cost of hospital care and follow-up amongst the inactive group, 5% lower amongst the pedestrian group, and 22% lower amongst the cycling commuters. We also looked at prescriptions, so I'm going to show you a graph now for prescriptions for anxiety and depression. Now, over the whole cohort, about 40% of people in the cohort had had a prescription for anxiety and depression at some point in that 18 years of follow-up. When we look at the average costs on a yearly basis per individual in the cohort, there's not really a great deal of difference between the inactive group and the pedestrian group, but there is a significantly lower cost for prescriptions for anxiety and depression amongst the cyclist group. Take you through some of the strengths and weaknesses, and you'll be glad to know I'm not going to go through every single point here, just what's highlighted in yellow. The main exposure variable we've used is limited because it's recorded just at one point in time in 2001. So respondents may have changed their method of commuting or stopped commuting completely. The other weakness I would point out here, we're unable to adjust for some potential confounders such as income and other forms of physical activity that contribute to total physical activity levels. That said, other studies that have looked at active commuting and health benefits have controlled and have been able to control for other physical activity, have still shown benefits from active commuting. The strengths of our study, it's a large representative census-based sample of the Scottish general population, a long period of follow-up, a wide age range. The prospective design and the adjustment for pre-existing health conditions allows us to address reverse causality, and we measured a range of health outcomes, including mental health, thereby providing a broad assessment of the positive impacts of active commuting. So I'm now going to just take a step back and what are some of the implications of this? If we want to get more people walking and cycling and wheeling, we need to invest in infrastructure. And giving an example here from Glasgow, I'm just going to give you some examples of what's going on in one city in Scotland. So we've got Connecting Woodside, which is an area in the west of Glasgow where they're improving the walking and cycling infrastructure for residents there. A similar approach, the South City Way in the south of Glasgow. We've got the Avenues programme, which is taking road space away from motor vehicles and making it more pleasant and easier for people to walk and cycle around the centre of Glasgow. We've had a low emission zone introduced in the last couple of months in Glasgow. We've got a bike hire scheme, which has been very, very successful, introduced in 2014 and is expanding across the city. This is a bridge across the Forth and Clyde Canal, which is connecting 3 communities that have been unconnected and are very deprived areas. We've got a proposal for a 20-mile-per-hour limit, similar to in Edinburgh, in the next couple of years in Glasgow. There's a bridge being built across the Clyde between Govan and Partick, which will be open, and this is a footbridge. There's a footbridge that's open between the Sighthill development in the north of the M8, taking people into the city centre. We have spaces for people infrastructure, which was temporary infrastructure brought in during the pandemic, much of which has been made permanent. And we've also got a bridge here in the East End of Glasgow. There's lots more going on, but this just gives you a bit of a flavour of what we need to make this kind of change. We need the infrastructure, we need the services to make it, encourage more people to feel it's safe and secure to travel actively. We do have some evidence from Cordon counts in Glasgow that, particularly for cycling, cycling has been going up over the last 12 years in response to some of these schemes and improved infrastructure. So there's about a 14% increase in annual cycling per year there. I'd like to point out, though, a few challenges, particularly with respect to cycling. Cycling and access to a bike is higher amongst higher income groups. Men are much more likely to cycle than women, and there are other groups who face barriers to cycling. So if we want to make this a just transition to a more sustainable transport system, we need to think about the conditions that we need to create to make it, to encourage more people to feel it's safe and okay to cycle. And that sort of links to my next point. Cyclist commuters are twice as likely as non-active commuters to be hospitalised, as our study has shown. Seriously injured cyclist casualties have risen in recent years in Scotland. 1 in 10 vehicles in a collision with a cyclist or a pedestrian doesn't stop. That's a so-called hit-and-run incident. I suppose my last point here is just, though, to emphasise that cycling is not overall a dangerous activity. At population level, cyclists have lower overall mortality, but perceived and real risks related to cycling do contribute to low uptake. So a few summary points here. Hopefully this has helped cement some of the health benefits that are associated with active travel, as well as the wider social and environmental benefits. Also, increasing levels of active commuting from relatively low levels in Scotland could take pressure off health services and save money in the medium to long term. But there's clearly a need to invest in safer infrastructure, particularly for cycling, in order to address safety issues and to encourage more people to travel actively. Policy is supportive, but progress in building active travel infrastructure is painfully slow. And there is resistance to lowering road speeds, to reducing car use and shifting investment away from roads. These are illustrations from an event we held about 7 or 8 years ago. These are the kind of discussions that were captured by an artist. We're rich in policies and strategies, but can we change the priority? Everything seems to revolve around the car. So, rather controversially for somebody from Glasgow Centre for Population Health, I'm going to finish with some images from Edinburgh. We criticise our politicians for many things, and these schemes have been controversial in Edinburgh, but if we're to make progress in a shift to a sustainable transport system, we need our politicians to invest in sustainable transport solutions and to stick to these decisions in the long term. And I'll stop there. Thank you very much.